there emerging approaches for treating follicular lymphoma that patients should know about?
There are. So there are some more exciting data that's coming out, specifically looking at CAR-T, which is chimeric antigen receptor therapy. So these are augmented T cells that they collect from the patient. They help to modify those cancer cells to recognize the tumor more appropriately, and they target those tumors to a receptor called CD19 that's present on the tumor. So that therapy has shown a significant overall response rate in follicular lymphoma, even in very heavily pretreated patients. Right now, we're still waiting on longer follow-up as far as the duration of response. But as of right now, there's a very encouraging therapy. The downside to that therapy is you can only receive that at select centers because they have to be a cellular therapy approved center. So you can't just go to sometimes your regular oncologist and say, Skoboken, wherever, and get this treatment. So that's one downside to that. And also it's a very expensive treatment and you need insurance approval to cover that. Some of the side effects from that treatment, we have gotten very better at controlling, such as cytokine release syndrome, which can cause fever, low blood pressures, difficulty breathing. That typically happens within a set period of time after the infusion of these modified T cells. And then there's also what we call neurotoxicity, meaning you can have some neurological complications, which again, we've become better at managing. There are a couple CAR-T products on the market right now. All of them seem very comparable and also effective in follicular lymphoma. There's also treatments called bispecific antibodies. These are like quasi off-the-shelf CAR products, except they use an antibody. And in this antibody, it has sort of two receptors. So earlier we talked about rituximab, which is a CD20 antibody. The bispecifics have a CD20 antibody and a CD3 binding site. So they bind to the tumor and also bind to your T cells. And with the binding to the T cells, they call T cell activation and expansion. And they will utilize your own T cells to fight off the cancer. So because these bispecifics are given as an off-the-shelf product, they will be able to be given in more accessible areas. So you won't have to go to select centers to be given. There are still some complications with those, such as CRS and neurotoxicity, but early reports indicate that they're much less severe and less frequency than what we see with CAR-T. But as of right now, also the duration of response of these treatments are still to be determined. So again, these are two exciting sort of avenues that are moving forward for patients with follicular lymphoma that will be further developed and sort of expanded on in the coming years.
I'd like to just go back for a second and ask you about inhibitor treatments.
Sure. So as of right now, CAR-T, or the chimeric antigen receptor therapy treatment, is only approved for patients with relapsed refractory disease. The bispecific antibody therapies are only available in clinical trial. There are some other sort of signaling inhibitors that have got approval. So we have the PI3 kinase delta inhibitors, which inhibit the PI3 kinase pathway in patients with follicular lymphoma. There were 4 approved agents in this class of drugs. We had umbralisib, duvelisib, capanelisib, and idelalisib. More recently, 2 of those, idelalisib and duvelisib, have removed their indications for follicular lymphoma. So as of right now, we have capanelisib, which is an IV PI3 kinase delta inhibitor, and umbralisib, which is an oral agent for the PI3 kinase delta inhibitor. So both of those agents are typically usually targeted in the third line and beyond, so patients who failed at least 2 lines of therapy. We also have tazemetostat, which is an EZH2 inhibitor that was more recently improved. So EZH2 mutations occur in about 20% of patients with follicular lymphoma. But tazemetostat was actually approved for those with and without the mutation, as it did show some efficacy in both. It appeared that the overall response rate was a bit higher in those who had an EZH2 mutation, but the duration of response appears to be equivalent. But I do think for most part, in that situation, for those who lack the mutation, this drug is typically used for patients who are unfit for other therapies, whereas those who have the mutation is typically probably will be used a bit earlier.
What about clinical trials? How do they fit in?
So for patients with relapsed refractory disease and even some patients with untreated disease, clinical trials are sometimes your best avenue for getting some of these new and promising therapeutics before they get approval. I know sometimes patients are very cautious about clinical trials because they don't want to be guinea pigs, but I will say all treatments that we offer you have started in clinical trials. And this is the only way to really advance the field. So if your treating physician has a clinical trial for you, I would strongly recommend patients consider that, because again, they're typically offering you something that they can't offer you as a standard of care insurance approved treatment. And for the most part, they're either adding drugs to what we do as far as a standard of care treatment approach, or offering you something that is very promising in the relapsed refractory setting or upfront setting that compares very favorably to what we would give you as a standard of care option, and allows you to get this option sooner and earlier when you're in better shape and less sort of beat up from some of the other treatments that we would give you.
Dr. Phillips, to close, what would you like to leave the audience with? Are you hopeful?
So I think follicular lymphoma and lymphoma in general, we are having a better understanding of the biology of the cancer, certain things that are important to the cancer, and certain avenues that we can treat the cancer and avoid some toxicities that have sort of plagued us before. So I think moving forward, there's a ton of research going into improving outcomes for patients with lymphoma and follicular lymphoma in general. There are a ton of other treatment options that are coming down the pipeway. So I think patients with follicular lymphoma should be very hopeful and encouraged that will continue just to improve their quality of life and also the duration that they can live with this cancer. I mean, as of right now, until we can cure this cancer, our real goal is to continue to buy you more time, and time buys you more treatments. And most of the treatments that we are developing and are coming, again, down the pipeline are, less toxic than some of the things we had, 5, 10, definitely 15, 20 years ago. So your experience and your quality of life will be improved, and these treatments will also give you more longevity than you could have ever expected. So patients with lymphoma are living a lot longer, and that's an important thing to remember. It's not hopeful. It's not hopeless, even though, we may say we can't cure your cancer. The goal as of right now is to turn this into a chronic disease, such as, like any other chronic disease, something that you'll live with, will manage and control, and hopefully you'll continue to enjoy your life, and your life won't be cut short by this cancer.